Good afternoon, everyone. We intentionally delayed the beginning of this session, waiting for our colleagues to come because they're still in clinics and surgeries, unfortunately, from the morning sessions. However, it's a great pleasure. Many of you have already met Sam. Dr. Sam Masket is a very well-known figure in ophthalmology and has been in the hospital now since yesterday. So you've been around and you've met many of our colleagues. Dr. Masket is a clinical professor of ophthalmology at the Geffen School of Medicine, UCLA, and a founding partner of Advanced Vision Care in Los Angeles. He has served on the board of trustees of the American Academy of Ophthalmology and is the past president of the American Society of Cataract and Refractive Surgery. Dr. Masket has published well in excess of 100 peer-reviewed articles and 2 textbooks. He serves on the editorial board of several medical journals, and he has been an invited guest surgeon and has given numerous named lectures globally. While his awards are numerous, his pioneering work with the femtosecond laser in 2004 helped lead to a revolutionary new method for cataract surgery. Currently, Dr. Masket is chair of the American Academy of Ophthalmology Senior Ophthalmologist Committee. His clinical and research interests relate to complex cataract and lens-based surgery. In 2013, Dr. Masket embarked on a new adventure with the establishment of the Samuel and Barbara Masket Foundation. The mission of the foundation is to provide ongoing ophthalmic clinical research to deliver state-of-the-art eye care for patients with inadequate resources and professional education. And since 2016, the foundation was able to begin funding patients. It's always a great pleasure to see one of the pioneers in ophthalmology visit KKH, this great institution that has had a huge impact not only on ophthalmic eye care in the kingdom, but also within the region, especially in the GCC countries. Dr. Masket, I know that your schedule is very busy, and I know that the trip was very long and the jet lag is a killer, and I understand the difficulty that you had to go through and stopping most of your clinical activities to join us today or this week. But it's a great pleasure and honor to have you here. This lecture is one of the lectures that are within the program for development of leadership within the ophthalmologist, whether in the residency or fellowship or even the consultants. The reason we have these lectures is to learn from the experiences of our visiting professors, whether throughout experiences that you had throughout your career or your personal life experiences, something that you can share with all of us and something that we can learn from you. So the floor is all yours for 1 hour. You can present as long as you want, but at the end we'll have around 20 minutes for discussions. Dr. Sam.
So good day again to those of you who were here this morning, and I appreciate your attendance. This is a non-clinical section, and I understand my mission is to share philosophies and a few other thoughts with you. One of the things that we face in the States, and I don't know if it's a problem that you have here in the kingdom, but we have a situation where physicians are burning out. We have a problem also where our physicians are aging, as is our population, and we have a workforce situation where we run the risk that we will not have enough ophthalmologists working long enough. Among the problems that we have, therefore, when we consider how do we have high-performance surgeons, with the aging population that we have and the reduced number of physicians per patient basis, is surgeons need to work longer, they need to see more patients, and among the problems that we have is one of ergonomics. So, as I say, every picture tells a story. This is LeBron James. The very famous American football coach, Vince Lombardi, for whom the trophy is named, said, "Fatigue makes cowards of us all." And what he meant by that was that if you don't prepare physically and mentally, then you run the risk that you're not going to be able to perform at the level you need. And in a football match or football game where physical combat is basically what goes on, it's very easy to quit. And quitting becomes a habit, according to him as well. So we know now that premium athletes spend, as LeBron James does, up to $1 million a year on their physical and mental well-being. We as ophthalmologists are also high-performance athletes in a fashion, only we're not paid the same amount of money. So we are underpaid premium athletes as I look at it. Our physical and our emotional well-being are central to our performance. I consider myself an influencer. My neck is on the cover of iNet, one of the journals of the American Academy of Ophthalmology. In schematic on the left and in reality on the right, I think you can see, let's use the pointer here. How do I make this point? Here we go. Although it doesn't show up on the screen, I'll show it here. Yeah.
Maybe you can do it on your laptop.
Yeah, I'm going to do that. If you see here, I have stenosis, and you can see here also there's an accentuated lordosis in my neck. This is a normal young person here on the left, and this is me on the right. So why is this? Well, every picture tells a story. The acrobatics that we go through in examining patients, if you take a look here in direct ophthalmoscopy in a chair rather than recumbent, slit lamp with oculars that are straight and maybe we're too far away, the chair is too low, and of course posture in the microscope. All of these things play havoc with our bodies. So we pay the price for long-term wear and tear. I trained in an era when there was absolutely no regard for the health and well-being of the trainee. I would spend, as an intern, up to 56 consecutive hours on duty. During ophthalmology training, there was never any discussion of how to best use diagnostic and surgical tools in order to reduce physical stress on me. The concern was only with regard to the surgical outcomes. If you work for the American Academy of Ophthalmology, not as a physician, but you get a job in an office at the academy, the first week you are there, you have an ergonomic evaluation of your workplace. Yet, if you go train in ophthalmology, nobody is going to take a look at your ergonomics. So I was really unaware of the impact of this long-term wear and tear in my body until I became symptomatic and had this MRI and discovered these findings. Now, as you can see here, this is not my neck. This is another prolific anterior segment surgeon, Steve Safran, who wound up having surgery for an unstable neck. And this is not a rare condition. So the problem is musculoskeletal disorders. There's an abundance evidence that ophthalmologists were at least two times more likely to have neck pain, 2.5 times more likely to suffer hand, wrist pain, and 3 times more likely to back pain than our family medicine physicians. Overall, these MSDs are more likely with age, more likely with hours of work, procedures performed, and with female gender. Probably because the design of the instruments, I always said, are for 6'3" Swedes who weigh 140 pounds. They're never designed for people who have shorter stature, shorter arms, or things of that nature. Here is the big issue, that MSDs are responsible for premature retirement among 15% of ophthalmologists. That has a potentially not only significant impact on the individual, but on the workforce. And so that's why it's a very, very important matter. This is a review article that came from the Canadian Journal of Ophthalmology, and I'll spare you all the small print. But what we can see here, and the red arrow points to it, is that they found 41 articles that related to ophthalmology and the OR and the impact on ergonomics. But only 9 of those 41 articles paid attention whatsoever to the trainee. So what are the solutions? What can be done? Well, workplace ergonomics is essential. So we as physicians need to work with the industry. Only one company, Hogstrite, will make angulated oculars, but they're not adjustable. They're just one, I think they're 22 degrees. They cost more, so you have to buy another piece of property, another piece of equipment. We need to get closer to the patient at the slit lamp, and so the stand itself can be modified to be shorter. The chair has to get closer. You have to shorten the distance between the patient and the examiner. And something else that has become of interest, and that is, instead of working through an operating microscope, working through a 3D remote system, referred to as heads-up surgery. I don't know if there's any interest or if anybody has seen that here at KCASH as yet, but it is growing in popularity. And what this enables the surgeon to do is to, rather than look through the microscope, the surgeon, in some of the models, wears 3D glasses, and they look at a remote image on a screen while they're working. It gives a hyperstereo. It's a wonderful, wonderful view. Some of the problems have included delays, and you have to look around a column, but they're all working on these things. So the traditional, what we call analog surgery versus heads up, has actually been studied, and we'll look at some of those things. In the States, we presently have 2 models. Alcon makes the Ingenuity, and Zeiss makes the Artivo. And again, both of these systems enable the surgeon to work without hunching over a microscope or working through a microscope in that fashion. And again, it's not a perfect system because the room has to be set up so that you can see a screen. There is some literature on whether this is advantageous in terms of the physical performance and the impact on ergonomics for the physician. A very interesting study was done by a young man by the name of Arjan Hura, who at the time he was a resident at Cincinnati Eye Institute, did an intraoperative EMG study, and you'll see here with a retina surgeon. This is the surgeon here, and he's got all these electrodes on his different muscles, and they studied him doing analog surgery and doing digital surgery. And these are the muscles they studied, basically the ones in the upper back and neck. The bottom line is that there was a significant difference in the stress on the muscles working digitally rather than through the analog. Again, I mentioned some of the problems of the digital system are that you still have the column of the microscope in front of you, and you have a remote screen. So you have to have space. You've got to be able to see the screen. And if you have, as you do here, virtually in every case where you have a teacher or an assistant, that can also create some ergonomic problems for that individual. So the next generation is a head-mounted system. This is called Bionics. And this company was a startup. It's now been bought by one of the larger companies in the U.S. And this is my partner, Nicole Fram, using this as a headset. There is no remote screen. You see everything like VR. It's very similar to VR. Not only that, the headset has a lot of information in it. You can tilt your head to the side. It'll bring up IOL power calculations. It'll bring up OCT. Many other things are available in that headset. The problem with this at the moment is that the headset is tethered to the system. So you have the weight of that on your neck. They are working on getting rid of that, having everything remote. So with the headset, you're not tethered. There's no extra weight or pulling you on your neck. So how do we change the system? How do we keep people working longer? You have to start very young. If you look at this pie chart on the right, this is the distribution of membership by age in the American Academy of Ophthalmology. 43% of ophthalmologists, presently Academy members, are over the age of 60. Our ship has sailed. I don't think there's very much we can do to try and undo what time has done. But 17% are ophthalmologists within their first 5 years of training, and the 38% are what's called mid-career ophthalmologists. It's this group here that we can really help. We have to engage industry in ergonomic design, and we have to engage the AUPO is the organization that determines training. It's the Association of University Professors in Ophthalmology. We have to have ergonomics as part of the curriculum in training programs. And in fact, at Wills, one of the top programs, one of the top 5 programs in the United States, they have incorporated it now. So some of us who have worked very, very hard to raise awareness of this problem have been successful. They're also doing it at the University of Michigan and some of the larger programs. So I hope that this message gets out around the world, that we consider the ergonomics of what we do and keeping us healthier. There's another thing that has happened. It's not just physical disability. Physicians are burning out in the United States and in the West. I'm not sure about the kingdom. So fitness for practice involves mental health as well as physical health. There are really 3 parts of that. So what is burnout? What is physician burnout all about? It actually now has a code. There is an insurance code for it. It's a combination of physical and mental fatigue that induces detachment from the job, reduces our work performance, and physicians can become angry and cynical. What has happened, and again, I cannot speak for the kingdom, but in the United States, it's associated with a lack of autonomy. More and more physicians are being employed by insurance groups, by hospitals, or are being purchased by organizations that buy their practices and then hire them as employees, and then dictate to the physicians how, when, and why they practice. This has led to an increase not just in job performance, but also in depression and suicide. The good news is that ophthalmologists are low on this list. This comes from a survey from an organization called Medscape, and this is a survey of roughly 12,000 U.S. physicians. You can see ophthalmology down here. Only 35% of surveyed ophthalmologists said they had symptoms of burnout, whereas critical care and what have you, physicians are much higher on the scale. Many people made the assumption that this was associated with the pandemic. But actually, it was the pandemic that brought this to light. in cities such as New York, Chicago, and elsewhere, Seattle, where physicians were forced to work very long hours, putting themselves at great risk and what have you. That brought it to the surface. But when surveyed, almost 80% of physicians who say they were burned out said it existed before the pandemic. The severity is also important. Of those who say they have burnout, more than half of them said it had a significant impact on their life. Again, this impacted women more than men, probably because of family responsibilities as well as practice. The good news is that rather than resorting to negative ways of dealing with it, exercise was the number one way that physicians dealt with it. And exercise is good for the mind as well as it is for the body. Burnout, unfortunately, can lead to depression. A significant number of physicians, 20% in fact, are saying they have severe depression. And this has led to an increased number of suicides among physicians. In fact, in the United States, the administration, the Biden administration, put through the Healthcare Provider Protection Act, which provides money for the mental health care of physicians. For those of you with more interest in this subject, I've written an article on it that appears in one of the American Academy publications called Scope on physician burnout and wellness. And again, I will provide you with my email address, and you can ask me, and I'll be very happy to send you a copy of this article on burnout wellness. Also, there are those on ergonomics. So that was some of the information that I wanted to share with you that was non-clinical, something that has become important to me as it had an impact on my career as well. But there are other things that we can and should talk about, particularly for young people. What are the responsibilities of physicians? From whom do we learn? How do we interact with our patients? I think these are all very important subjects. Practice has changed a lot over the years. When I first went into practice, it was illegal for physicians to advertise, as an example. You could not be a member in good standing of your local medical society if you advertised. You couldn't be a member in good standing of your local medical society and get hospital privileges and insurance coverage if you split fees. But this is commonly done now in the United States with what, they call it different things. But it really is fee splitting when we co-manage patients. It's commonly done in refractive surgery, where the optometrists send patients to the refractive surgeons, and the optometrists are paid a fee. So philosophically, things have changed a lot. I'm very cutting edge in what I believe in surgically, but I'm very old-fashioned in what I believe we should do in terms of medicine, ethics, and things of that nature. I hate social media. I really don't like Instagram and things of that nature. But it's easy to get caught up in it, and it's not regulated. Anyone can put anything they want. They can say they did 43,000 surgeries yesterday, and there's nobody there to say they did or didn't. So does the physician, or is the physician subject to a higher set of ethics than is somebody else? We do take a code of ethics. I believe very strongly we owe this to our patients. And across my career, there have been a few physicians who had a great impact on how I practice. One of them said to me, never do anything about which you could be embarrassed. Don't abuse your medical license in a bad way. That stayed with me. Another of my mentors, one I consider among the most important, taught me about honesty with your patients. Never lie to your patients. Always share truth with them. It raises the question, how much should you tell your patient about complications and other problems that you share, that they experience? I've always said to my patients, it is my job to worry about you. It is not your job to worry. If there is something that I need you to worry about, I will share that with you. So there are certain things that will occur in surgery that may not be perfect as you would describe a surgery, but may not impact that patient long term. An example might be a radialized anterior capsulotomy. You're still able to put the lens in the bag. You're still able to put the lens you want, more or less. In that situation, I don't think the patient needs to know about that. However, if you drop a lens, if the patient has nucleus in the vitreous, on and on and on, and they need another surgery, you need to explain to them in terms that they can understand what happened, but not just what happened, but what you are going to do to assure that they have a good outcome or a better outcome. You may need to refer them, but you're going to talk to that other physician, maybe a retinal specialist. And I always felt that it was important, if I needed to refer a complication, that I went to surgery with that complicated situation, so that I was there to make sure things went as well as possible, and the patient knew that there was that communication, that relationship between me and that patient. So talking to the patient, there's a book that just came out about what I say. That's the name of the book. I have a chapter in there in which I was asked to write about what I tell the patient who wants to have femtosecond laser surgery, why they should do it, when the literature doesn't really support its use. So you need to explain to the patient why you think they would benefit. And I had 5 indications for femto: compromised endothelium, shallow chamber, nuclear issues, very dense cataract, zonulopathy, and what I call special capsule issues like lenticonus, posterior polar cataract, things of that nature. So communicating with your patients is very important. What I learned from another mentor is you can't have a bad day. When you go to see your patients, you have to leave everything behind you. I don't know if you're familiar with the book called The Power of Now by Eckhart Tolle. It teaches us that we live only in a certain moment. What happened in the past, we cannot alter. What will happen in the future, we cannot impact. We have only this moment to deal with. And that, he talked about, he didn't really explain how you get there, but each of us have ways that we get to the now. I could get to the now, so to speak, in surgery. I could tune out everything else as you must. If you have a long list and you're early in that list, you can't say, oh my gosh, how am I going to get? You're only dealing with that patient at that time. That enables you to deal with complications, It enables you to deal with complex situations. It enables you to deal with VIPs, family members, or what have you. So if you can focus, I think that's how most ophthalmologists get into the now. Some people, like those who like climb Mount Everest, can only get into the now when death is on the line. I'm not among them, but it's only me in that eyeball. So I think it's very, very important to focus on what you're doing. I learned early in my life, in college actually, that if you want to play hard, but do it in a certain time period. When you want to study hard. Compartmentalize everything rather than mixing everything together. And then you can tackle a lot more issues that way. I think I've shared as much with you as I possibly can, and I'd love to have an open conversation about any of these matters.
Thank you very much, Dr. Masket. That was a very important topic and some very inspiring advices that you gave us at the end of the lecture. Okay. So, are there any questions from the audience? I will start with one. Based on your experience now and after so many years, and since you've learned it the hard way, and many of us actually have been through that, and some of us are still going through it, what is your advice for the best posture when you're doing surgery? Should you have the microscope straight? Should you look down at the microscope? What's the best position?
If you're pushed forward, the impact on your spine is massive. And most people tend to reach forward like this. You never see surgeons reaching back. But the load on the spine is terrible if you're leaning forward. And the impact on your neck is horrible if you're looking like this. You can imagine a line going from the middle of your head down your spine being vertical. So looking straight ahead, sitting erect, and working with your hands in this position is the best possible way.
So try to always to look straight and not look down at the microscope.
No, not look down, but have the oculus straight ahead. So your neck is not this or this. Neutral position.
Excellent. Are there any exercises that one can do before surgery to strengthen the muscles?
Many surgeons are now doing Pilates or yoga before they do surgery. I'm not an expert in this field, but I've heard people speak on it. There are a number of exercises that people can do. In fact, some of them are neck twisting and what have you. I wish that I had that information and had some of the slides with me here. But there are a number of physical therapists who are now teaching. We have ergonomics courses at the academy meetings and what have you. And they involve mostly neck and shoulder exercises, and absolutely they can be done.
Great.
But I'm not expert in them.
Is there a specialist who would, since I joined KKH lately, I've been looking for someone who's an expert on ergonomics, and I wanted him to come and observe all of our surgeons and see their posture and then criticize them or tell them what's the best way and how they can improve it. But I couldn't find anyone who specialized in that small field. Does it have a name? Is there such a subspecialty? Do you know of someone?
We had a physical therapist as part of a course we did, whose name I can't, but I promise you, I will get you that information.
Yeah, we'd love to bring.
I will point somebody to you.
Yeah, it would be nice if you could come and join us and
'Cause
just
I'm
observe
not
how our posture is in surgery.
I think the problem, again, for people who have a lot of experience is that teaching an old dog new tricks is difficult. I think making it part of the training curriculum,
Exactly.
I think, is essential. If you take people before they have developed their habits, many of us who have developed bad habits adapted to them. And getting us to move out of them, I think, will be very difficult. But starting young. But I can think of people who I can contact and get them to you.
Perfect. Any questions from the audience? Tafadhal.
Hi, Doctor. First, thank you for this beautiful information. Secondly, I'm pharmacist, actually. I have a questions from burnout in the medical field as general, not only for the physicians. I always ask myself this question. I don't know it is right or not. For anyone need to attend to the medical field, I think he should get a specific behavior or criteria, or believing that what he is really doing, it is so special and it's very important to the society. So he cannot get this burnout with the time. I got some of my colleagues, I just ask them why you are here. So they just say, it's a good job. So with the time, I feel this is lead to the burnout of the work. So this is my questions. If we can learn each one before attend to the medical field, why you want to attend to this field. Thank you.
So if you allow me to summarize, what you're saying is that if we look at what we're doing as a mission rather than a job, then burnout would be less.
You know, one of my mentors also taught me something that I've remembered for a very long time, and it really answers what you say. When I went, he was the chairman of the department where I trained in ophthalmology, and I was a medical student, and I got exposed to ophthalmology, and I thought that I wanted to consider it as a career. And I went and I met with him, and he said, only consider it if it challenges you and stimulates you intellectually, otherwise it'll just be a job. And those words have really stayed with, and they're very, very true. I think I took it too far, though. I think ophthalmology dominated a little bit too much of my life. I enjoy the science very, very much, and I've always found it challenging, and that's why I've always, tried to answer questions that were previously unanswered. Maybe because of how he stimulated me or not, I don't know. But that was a very, very important message. So your answer to those friends is, don't do it as a job. Yeah.
Passion is the drive to your success. You have to have passion in what you do.
Absolutely.
How many of you thinks that let's say medicine now is shifting into being a job rather than a mission? We're seeing lots of new generation physicians who believe or look at this as a job, and they think of it as a job, and when they choose what subspecialty they want, they go to the subspecialty that brings more money or fame. Mm-hmm. And it's not anymore my passion or what I feel or what I love or what I enjoy. It's more what makes me, in a better financial condition. And why do you think that this is happening? Is it because we failed in our teaching of the new generation? Is it because the whole community is changing, the mentality is changing? Or is it because of the influence of industry and the insurance companies that are driving this to be more of a job, 1 + 1 = 2, and it's not about the patient anymore?
Well, we are just a microcosm of what goes on in the world. So among the things that bothers me, but again, because I'm older, maybe I look at changes as being bothersome rather than accepting them as they are. But celebrity has become way too important. I like to say the Kardashians as an example. They're famous for being famous. They have added nothing to the world. But with celebrity, look at our professional athletes, the salaries that they command. So money, in my view, has become too important. when I decided to become a physician, never was there the thought of creating wealth. I mean, we always knew physicians would live well and make a living and be able to raise and educate and house their families, and live a good lifestyle. But it was never about accumulating wealth. We're just a microcosm of what's going on. I mean, it's a paradigm shift. I don't think that we've caused it or can influence it. I think it's too big. It's too big.
So where do you see medicine in 20 years?
Well, I think that the physician, as you and I know the physician, is being replaced a lot by technology, and a lot by what I'm saying would be what I call any willing provider, people who are not physicians, but are physician-like individuals. The example I use, when I was in training in medical school, the king was always the cardiologist, because the cardiologist could use that stethoscope and hear little clicks and rubs and murmurs that most other people couldn't hear. Today, the cardiologist doesn't see the patient. I mean, everything is printed out. How to read an EKG was a great art. All of those things have been replaced by technology. So the relationship between the patient and the physician has changed. A lot is also cash-based. That has changed. So where do I see that, again, medicine may become more health-based than disease-based, where disease-based can really be done by technology and other providers. And maybe physicians will be overseers, and also maybe will move more to health-based than disease-based medicine.
Thank you. Any other questions؟ بمشي بالدور. تفضل.
Thank you, Prof. Masket, for the lecture. My question is actually about the future. There's a lot of young ophthalmologists, speaking of the power of now, they don't think about now, they think about their future. As a young ophthalmologist, you either think that you could be a leader and you can make a change in your society, or a competent clinician and you help your physician, or a researcher and you make an impact in ophthalmology. And I'm sure you've done all these three roles throughout your career. Is this something that can be doable and you can balance between the three, or should someone just choose one of these three paths and just follow along with it?
I think that has to come from within. One of the great things that age teaches us is who we are. I think as a young person, it's hard to know really where your passions lie. You have to be honest with yourself and say where, for example, when we interview candidates for fellowship with us, the very first question I ask is, where do you see yourself professionally in 5 years or 10 years? What do you want to become? And I think you hopefully can know this at a young age, but it's harder. It really takes, water under the dam, or under the bridge before you know what you want to do. It's a hard question to answer, but you spend time with yourself and you think about it. One of the other things we didn't talk about also is life outside of medicine. Many younger physicians today, the question is lifestyle rather than the profession. And again, is that good or is it bad? To me, I look at it as a shift, a change in the paradigm. I think it's important to spend time with family. And balancing time, particularly for women, is impossible. It's very, very difficult. We can never change that the women bear children. And I've watched my partner.
Barbara is agreeing with that.
I've watched my partner, who, in the better sense of the word, I call her an animal, because she can't get enough ophthalmology. But she has one child, and I watch that relationship. And it's just, the balance is very difficult. So I think early in your life, you need to say to yourself, what do I want? And then you also have to, if you have a partner, you have to discuss it with your partner. Your partner needs to be involved in that decision-making as well. Because my partner's in the room, and if she didn't have her own career, I could not have accomplished the things I did. Now, I'm not saying that's good or bad, but that's also something that you need to discuss. So it's a tough question you ask.
Thank you. Rashid?
Thank you very much for this excellent talk. My question, to protect from burnout or delay it, do you think it is advisable if we arrange once or twice per year visit for the physician to the well-being clinic, which is run by the professor of psychology?
On a routine basis?
Thank
you. One of the things I didn't discuss, and I know that you don't have the problem here in the kingdom, we have a problem of as I mentioned, 43% of us in the academy are over the age of 60. We have a problem with the aging physician. And at what point in time that physician needs to consider changing his or her life or practice. When are the manual skills? When are the cognitive skills? Are they deteriorating? So I would like to see us evaluated not when we turn 60 or 65 or 70, what have you. I would like to see us evaluated periodically from the time we start until when. And I think we should have objective and subjective testing of physicians. And if at some point, whether that be at 43 or 83, if our skills erode and our mental well-being is being impacted and affecting our work, I think this should be known. So I think psychological evaluation is just part of that. But I really think, as I said, I think we are underpaid high-performance athletes. And I think, when we look what they go through to get themselves ready to play, I think we need to do to get ourselves ready to work. I mean, there are more than 8 billion people on this planet now, and there are just more and more people who need our care. So I think, yes, I think we should have not necessarily just psychological evaluation, but I think we need evaluation of all our skills and our well-being over the course of our career.
Thank you very much. From that side.
Thank you, Professor Masket, for this nice talk. My question is all subspecialties affected the same way according to the back pain, or there is some subspecialties that are more in danger to have a back pain compared, because I see myself as a vitreoretinal surgeon and my colleagues in oculoplastic, and the exposure is totally different. So there is any data about exposure, or all ophthalmology careers are affected the same way?
I don't know, or I'm not aware of data that looks at subspecialists in terms of their own or that particular specialty and the impact on ergonomics. I think the retina people may, because of indirect ophthalmoscopy, and I'll give my training credit for this, when I was trained to do indirect ophthalmoscopy, it was never done in a chair. The patient was always recumbent on a table. But still, we were, I think retina may suffer more than others, but I'm not aware that there's data. There is either data evolving or out there, but I'm not aware of it in the literature.
Professor Khabir.
Thank you for a very good talk. And I have one suggestion. And on my orientation day, When I was doing my PhD, my supervisor, the first lesson I got from him was how to sit in correct posture. So it really helped me all my life after that. The other question is correcting incorrect postures. And it is a conscious and constant effort. And I just was wondering whether one can ask, like a supervisor can ask his residents and fellows to correct their positions if they are in incorrect postures, and vice versa, and whether it would be professional in a workplace. Thank you.
Well, I agree that this should be part of the training curriculum. I would like to see it really put in practice, and I agree fully that we should have evaluation. As I said, if you go to work for the American Academy of Ophthalmology, just as a clerk, you will have your workplace ergonomics evaluated within the first week, all right? But we don't do it for our trainees. But yes, it should be absolutely, we should, absolutely, teachers should look and say to, listen, you're sitting too close, you're sitting too back, your neck is twisted, because it's going to take its toll.
Okay, we have 2 more minutes. I'll ask you the final question. I worked with you, I visited you for 1 day in 1999, and at that time I was a junior consultant. And I was struck by how nice and sweet and welcoming you were to me, both on a personal level and only on the scientific side. I mean, you did not stop explaining every little step that you did during surgery. And my question to you is, how can you keep being humble and nice to people, patients and junior staff, after many years and long experiences and being well-known, famous, respected? How can you keep your personality and be still humble? What do you do to remind yourself always to be humble to people? Because we've seen people of lesser stature that within years of being consultant, they turn into, let's say, another beast. So what is your advice to them? What to do?
There are 2 answers. One, never read your press clippings. Meaning, so when anyone says great things about you, ignore them. Second, and I always practice this way and always taught this way, you're only as good as the next patient for whom you care. So whatever you did before doesn't count. What you're doing now, what you're doing for that patient or that trainee or that person is what matters. Ignore your press clippings and realize that everything you did in the past doesn't mean anything. It only means something to what you're doing now.
Thank you very much. And with all of that, we conclude this session. I thank you all for coming. Sam, we have a little souvenir from Kekish that we always give to our international